Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. Today on the podcast, I'm speaking with Dr Ruth Abrams, an organisational psychologist and associate professor at the University of Surrey School of Health Sciences, about her recent research published in the British Journal of General Practice on the conditions in which women GPs thrive. Ruth discusses why women GPs experience disproportionate rates of stress and lower career progression, and talks about the medical gender pay gap. She also outlines 5 practical actions individual GP practices can take right now to foster a fairer, more flexible and supportive environment. Ruth also highlights critical gaps in current research and explains why we need a national systemic policy change to ensure workforce sustainability, rather than simply telling individuals to be more resilient. GP Online has joined forces with 5 essential healthcare resources to create the MIMS Healthcare Network. Since 1959, our Haymarket healthcare titles have supported primary and secondary care audience across the UK through individual publications and specialist events. We're now entering an exciting new era with the launch of MIMS Healthcare Network, linking together our 6 leading media brands to serve the entire healthcare community as one. The MIMS Healthcare Network covers GP Online, GP Business, MIMS, MIMS Learning, MIMS Learning Live and MIMS Pharma. By bringing together these resources, we aim to provide a seamless experience for all healthcare professionals and the organisations that support and supply the UK health sector. The MIMS Healthcare Network, covering every aspect of primary care. For more information about our subscriptions, visit GPonline.com/subscribe. I'm delighted to be joined on the podcast now by Dr Ruth Abrams, who is an associate professor at the University of Surrey School of Health Sciences. Ruth is an organisational psychologist whose research focuses on the primary care workforce and primary care service design, delivery and evaluation. She's particularly interested in the organisation of general practice and women in healthcare, and she's here today to talk about her recent study published in the BJGP about the conditions in which women GPs thrive in general practice. Thank you for coming on the podcast, Ruth.
Thank you for having me. It's a real privilege.
You're an organisational psychologist and a health service researcher, and your research focuses specifically on sort of around primary care. How did you become interested in this area for research?
I mean, essentially, I've always had a real interest in how our work comes to shape our health, our well-being, and also just very generally our ability to exist in the world. So long before I came to academia, I worked across a range of different organisations where I was kind of shaping frontline experiences of health and well-being. And I really wanted to know more from the kind of organisational level about why this kind of seemed so hard to do, and at times why it came across as quite tokenistic. And so that's where my organisational psychology lens came in. And then I went on to do my PhD, which specifically looked at women in the workplace. And so moving into NHS research was quite a natural fit and home for me because it's one of our largest employers in the UK here, and it's very complex in structure, so has that inherent interest for me about how we unpick it and figure things out. And also the workforce is predominantly made up of women as well.
What in particular made you interested in primary care?
I guess it's something for me that we all come into contact with. So, we are all patients, every single one of us. And so that for me, it's such an important role in society. It spreads out so far. And that for me just felt so inherently interesting that I thought, that's where I really want to be.
So this latest bit of research that you've published in the BJGP, the British Journal of General Practice, it's about the conditions in which women GPs thrive in general practice. How did that study come about? What did you want to look at in that specifically?
From a personal point of view, it was an opportunity for me to bring various different strands of my previous work together. So it kind of had women at work, wellbeing, the NHS. And I'd started to see kind of increasing talk about GP wellbeing just very broadly, particularly kind of after the pandemic. In another review I'd been involved in that was led by Heather Gage at the time, looking at GP composition, I'd seen literature there talking about the differences in gender, particularly around team composition, well-being, the implications of that. And so when I started to delve a little bit more into the literature and the evidence base, I kind of began to see the extent of the problem in terms of how differently women are affected by things like career progression, stress and burnout. So that really for me was the starting point for the study.
In the study, the bit at the beginning of the study, you say existing evidence shows that women GPs are affected by lower rates of career progression and higher rates of stress, emotional exhaustion and anxiety at work. Do we understand why that is?
In part, yes. But as I'm sure you can imagine, with these things, it's never just one factor. And we always have to be quite careful about how we attribute causation to why these things happen. So, in the review that I've just led, it was specifically designed to be able to attribute a degree of qualitative inference as to why women kind of experience these lower rates of career progression, high rates of stress, emotional exhaustion, and anxiety. And what we found was that women GPs in some cases are specifically sought out by certain patient groups because of what they do in those consultations. So they listen closely, they explore the psychosocial questions, explain treatment options, and support holistic decisions. And it's certainly not to say that male GPs don't do that. They do, but it's slightly different for women. And in these consultations, we were finding that multiple benefits arise, like stimulating greater patient disclosure. And so all of this has a knock-on impact in that it's a heavier emotional labour, it increases the consultation time, and none of this is inherently damaging in isolation, but it's the fact that this type of work is both unrecognised and unrewarded in the current system. And so when you couple that with gendered expectations around caring roles, higher rates of mistreatment, which women experience as well, and also reduced leadership opportunities because they fall outside of the traditional contracted hours, that's when you start to see that risk of stress, exhaustion, the implications on career. And so that, yes, that all came out as a result of our review. And there's also been some other work by one of my colleagues, Laura Jefferson, as well, who looked very specifically at the barriers and facilitators to women GPs' careers in a systematic lit review.
Women GPs also experience one of the worst pay gaps in medicine, despite them making up more than half of the workforce. Why is that? Is that to do with more part-time working?
It is, yeah. And I guess one of the best resources that I would signpost here, which really interrogates and pulls this apart, is a report that came out in 2020 by Dame Carol Black and Carol Woodhams. So part-time working does very much account for this, but it's also the knock-on and the implications of that. So what I mean by that and what they articulate in their report is that implications of less than full-time working have that effect on women's ability to progress into more senior roles that traditionally pay more. And as the report indicates, these are often held by men who are older. And so it's that kind of melding pot of different factors. But yes, in answer to your question, part-time work has a major factor in that.
And so this latest bit of research which you've done, how did that work? What were you actually doing and how were you kind of assessing all the things you were looking at?
We first started the project in 2024, so it was an 18-month project, and it was funded by the National Institute for Health Research, specifically the Health and Social Care Delivery Research Programme. And it was to undertake a realist review, as we've discussed, to mention it, to identify the conditions in which women GPs can thrive in general practice. And so the approach that we were taking, a realist review, what I mean by this is it's essentially an approach to reviewing existing evidence that allows us to move beyond simply saying kind of what the issues are and what the potential solutions are, because we interrogate using the particular methodology, looking for patterns to explore what works for whom, how, and under what circumstances. So you're bringing together a whole body of evidence to identify those patterns. You're looking for the kind of generative causation, which allows you to make that inference qualitatively based on the evidence. So our role was to bring all of that together, and we reviewed over 1,000 documents there, 72 of which were kind of really core to our research questions. And also what I chose to do with the study was overlay a theoretical framework of thriving. So this is a concept that's been predominantly used in positive psychology and organisational psychology, where it has over 2 decades worth of research and evidence. And I guess my reason for wanting to have that theoretical framework is I wanted the study to have something hopeful and aspirational to work towards, as well as exploring the existing conditions too.
You mentioned questions there, and the study looks at a number of key questions. What exactly were those questions you were trying to answer?
So we had 5 key questions that we set out to achieve, including, so what are the mechanisms acting at individual, team, organisational and societal levels that affect women GPs' health and well-being, performance and career progression? So they were our 3 kind of core outcomes that we were very interested in. We also wanted to know in what context these mechanisms are triggered. So what I mean by mechanisms here is it's almost like they're the hidden magic ingredient of why these things are happening. And then we also wanted to know what outcomes, both intended and unintended, do these particular contexts and mechanisms lead to? What, if any, are the interventions and strategies that can be implemented to help women GPs to thrive at work? And then finally, we wanted to also identify the critical gaps in the literature.
Can you kind of summarise some of the key things you found when you were looking at those questions?
So we've already mentioned about some of the patient-facing findings. What we did with the findings is group them into 3 core concepts. We had patient-facing work, navigating competing demands, and sustainable careers, leadership and success. And what we kind of found with each of the findings is that every time there was an opportunity for women to thrive, it was also equally undermined by another condition. So that often there was this real kind of push and pull going on. To give a bit more of a detailed snapshot is the evidence would suggest that women can often depend on strong social networks for support to help juggle clinical work with caring responsibilities, but they continue to face intense pressures to excel in every role. This strain can be particularly amplified in early career GPs with young children, those from minority backgrounds, where cultural expectations can heighten that load. When workplaces expect overtime or inflexible schedules, women GPs have less capacity for leadership, training or practice ownership, and that can slow down their career progression and increase dissatisfaction with the job. In terms of thriving, what we saw there is that many can turn to a flexible or portfolio role, part-time working, to regain that flexibility and control over their schedules. But to caveat this again, which kind of shows the contradicting nature of how they do thrive, taking on that with those part-time hours can often be undervalued and not actually really lead to part-time working. So really what we need to create here is environments that genuinely focus on supporting flexibility, recognising all work patterns are really essential for women GPs, and particularly where things like autonomy, energy and sustainability are fostered. And then also just a few other very brief nuggets, but career enriching support is really essential. So supervision groups, mentors, healthy practice dynamics, acknowledging that success might look different for different people. They're really essential factors as well.
One of the things that struck me when I was reading it is that you found that the very thing that gives women GPs sort of deep job satisfaction, which was taking a holistic, patient-centred approach, is also a major driver of exhaustion, because the system, as it were, the NHS fails to acknowledge the additional emotional and physical impact that has. And also that women GPs often attract more complex patients. Why is that, and what's the impact of all of that?
With why this happens and the impact of it, I would say that it doesn't have to be this way. It's partly a social conditioning response, is partly a historic response, but the reason why in some cases women traditionally attract more complex patients can be attributed to these gendered expectations about how women care. So last year I wrote an editorial for the BJGP with the title Mind the Expectation Gap, and in it I was talking about the double bind that women GPs might encounter, because what we see here is that women GPs are expected to exhibit stereotypically female traits of deference, empathy, warmth, approachability, likability. And at the same time, they're also required to embody a slightly more stereotypically masculine trait of dominance, so asserting that kind of 10-minute appointment time and having aspirations and attainment for partnership and leadership roles. That's kind of really where that double bind is. And also at the same time, that the real challenge here is that patients do have a legitimate right to ask for a specific GP, especially for things like women's health appointments. And then there may also be areas of speciality that by choice a woman GP has decided upon, and so volitionally take on those more complex appointments. And again, it kind of goes back to my earlier point of all of this is only an issue when women are then perceived as inefficient in the system because those appointments take longer, which inevitably will then lead to those feelings of perhaps perceived failure, perceived inability to cope within the current system. These are very kind of historic societal perceptions that we need to kind of carefully interrogate.
I just find all of this quite interesting. Women are perceived and there's certain female traits and male traits. And I just think that in a job like general practice, I suppose it's because that was the first sort of area of medicine to a certain extent that became really dominated by women. I mean, I know more women go to medical school now than men, but general practice is one of those areas of medicine where you saw more women coming in, and there's often been a bit of pushback from various people about that and about what it means because of resistance to part-time working. And it's interesting now because I think that things have shifted a lot, haven't they? And men want to work part-time as much as women, and society is changing in many, many areas, and we need to kind of keep abreast of all of that, don't we, and understand that people's roles are not necessarily as defined as that anymore, that the woman is the person that does the childcare and the man is the person that goes out to work. It doesn't work like that anymore.
Absolutely. And I'm really glad you mentioned that, because one of the things that I have encountered from doing this research is pushback from various different spheres. And it's been a very interesting point of reflection, actually, because it's really important that we do acknowledge that this is affecting the majority of women who work in general practice. And also, some of these things do also affect men equally. Not all of these things affect all women. It's very complicated. And kind of like you're saying, that shift in role, whilst traditionally it's still not seen in general practice, in order to allow that shift to happen, we do need to now pay greater attention to, for example, how men access paternity leave. Just as a very kind of quick example, and I was having a conversation with a colleague about this yesterday who's doing some research into female surgeons. And, in order for that balance and that recognition to come into the workplace, how we treat everyone and what flexibility means really needs interrogating, because if you don't allow paternity leave for men, you push it back onto the woman.
What can GP practices themselves do to kind of recognise the challenges that women in particular have? Do they need to think about things like redesigning appointments, and how can they recognise that maybe women have those emotionally demanding consultations that we were talking about earlier?
Yeah, I mean, I think the consultation point is probably the biggest, and I think it's the one that, whenever I've had conversations about this research with women GPs themselves, it's really the focal point, because it's probably the most accessible one to change. And so the simplest solution, and one that I've heard other GP practices build in, is to just simply either extend the appointment time for complex cases or distribute that workload across the entire team so that it does become more balanced. And so that really requires people to pay attention to individual and team needs across the practice and help create that more equitable workload balance, bringing it out into the open for team discussion, not positioning it as a failure. All of these things will help to retain the inherent meaning and job satisfaction, and also just surface the assumptions about, this person always takes these appointments, so therefore they can carry on with this.
That's good advice as well. We've talked a lot about part-time working. Obviously, the irony of that, as I often talk about on the podcast with my colleague Nick, is that part-time working in general practice isn't often part-time working. A 6-session week easily translates into a full-time job in other sectors. Obviously, part-time GPs often face differential treatment or lack of respect, you talked about in the study, for being part-time. Do you think we need to change how we define measures and how we value workload so that part-time options actually protect clinicians instead of hiding full-time work?
Yeah, I mean, this is something that we found in our evidence, and I know that the RCGP are also doing a lot of work into hidden workload as well, and I think this constitutes part of that idea. Probably what needs to happen here is the heralding and upholding of multiple different career options for both men and women, and for these models to be visible, viable. And I know that sounds quite idealistic, and I'm a firm believer in there needs to be this kind of aspiration. I think probably what we see in general practice a lot is this absolute thinking, and what I mean by that is, this is how it is. It's always been like this. We're going to just keep doing what we're doing. And really, for the system to kind of innovate and transform, there needs to be a kind of switch towards a more conditional thinking. And that just means we're seeing it for what it is and also seeing it for what it could be. And I think learning from other practices where this type of innovative workforce strategies are coming into play, where they are changing appointment times, they're, celebrating different career models, that really is where the change needs to start.
One of the big criticisms in your paper is that the medical literature places a heavy reliance on telling women GPs to fix their own circumstances, to do better at self-care or set boundaries, rather than it being an organisational problem. This is something that's been a kind of thing in general practice for quite a long time, generally about this idea that burnout and stress is something you've got to manage yourself, rather than recognising the fact that because it is such a problem in general practice because the system is set up in such a way that makes the job so demanding. I mean, why is that narrative so damaging for workforce retention?
Yeah, I mean, I think probably what we need to do here is situate it in a much kind of broader societal and historical narrative as well, in that we live in a very neoliberal society. And so there's a very strong emphasis here placed on reduced state support, and we see a kind of underfunding of public services. What inevitably happens there is it becomes slightly easier to push back on the individual and it individualize and put responsibility there. What we start to see with that type of narrative and framing and societal positioning is that things like, say, gendered pay gaps become an individual responsibility down to the skill of an individual to negotiate their own salary, or it positions burnout as the fault of the individual for not being able to cope. And this is really damaging because it reduces kind of any type of collective action. It fosters and relies on a sense of failure, which is perceived. And this doesn't affect just women, it's everyone. I guess it's slightly stronger for women because, again, the social conditioning that we have, it means then that organizations are quite constrained in what they can do to support, because it becomes much easier to just push those individualized solutions in isolation because there's so much short-term thinking. And I think it's really important to stress here that this is not the fault of anyone. It's the environment that we now find ourselves in that we have to move beyond. And I guess one of the ways that we move beyond doing this is by talking about it and kind of pointing a finger at, this is what we're living in right now. When we talk about the system, it's kind of naming and describing exactly what that is and why that's happening, so that we can begin to have those bigger conversations about workforce retention and what does it look like to put in a systems level intervention or organisational level intervention. And they're hard conversations to have, but it's not in a vacuum.
The other thing that women have to deal with quite a lot is sexism and sexual harassment. And you mentioned that in the study. And we're talking about sort of sexism and sexual harassment from both patients and colleagues. You also note in that paper that these experiences are amplified for women with intersectional identities. What are the sort of immediate practical policies that practice managers and GP partners could implement in their surgeries to make sure that they're safe spaces and that they can combat this kind of behaviour?
So there is some evidence to suggest that initiatives that challenge those implicit biases, such as, for example, the provision of professional name badges, can help to counter misperceptions in general practice. It's also really important to ensure that the reporting policies are visible, accessible, and that responsible use is encouraged. I think also it's really important here to pay attention to the people in the middle. And what I mean by that is when things are reported, it's knowing how to listen well, hear, and also then act on and feed back how that particular incident or scenario has been dealt with. And that requires support as well, because again, we're talking about real people here, real people who are holding these spaces and acting, and not everyone knows how to do that. These again are difficult challenges to face. And so I think it's really important that the risk and the blame is also surfaced in terms of how people are responding. But ultimately, a lot of these initiatives that we kind of hear about haven't yet been evaluated. And so that's also another step that needs to happen is what is the impact of any kind of initiative that's implemented, and how are they being evaluated and improved upon, really?
The data in your study showed that more experienced women GPs report higher well-being because they've developed strategies to handle some of the challenges we've been talking about over time. But you say that early career GPs, women GPs, are at much higher risk of leaving the profession early due to the kind of things we touched on, like competing demands with childcare. What do we need to do to ensure that younger women are better supported and not lost to general practice?
Yeah, I mean, one of the ways, again, in the evidence, and I do caveat this with acknowledging the fact that what I'm about to say is a slightly more individualised response to this, and also it does work. And in the absence of anything else, as an interim, things like mentoring, peer support groups are really, really essential here. They don't just need to be women-only spaces. However, there is evidence to show that in some cases, those women-only spaces can enhance feelings of belonging, professional confidence, competencies. But when it comes to things like mentoring, that really can be a match of anyone. And I had a really wonderful conversation with some women GPs at a local surgery a few months back where, one of the reflections from a woman who had been in general practice for a long time was this idea of, I can do this, I can mentor these younger women coming in. And, it was such a perfect kind of light bulb moment for the skills that she had developed throughout her entire career to be able to pass those forwards. We shouldn't forget the value in those connections.
I think people further along in their career, I mean, that they often find that is a reason for them to stay for longer as well, because they get a lot out of that mentoring and helping younger people. So it's positive from both sides. Yeah, I can see how it could definitely help here with general practice. Based on your study, I think it's probably worth trying to sum some of this stuff up. What would you say are the key things GP practices need to take from it to better support the women GPs that work for them? And I was just posed as part of this, is it different things that female GP partners need compared with salaried GPs?
Well, in response to your latter question first, I would say we don't have enough evidence to be able to really articulate the delineations there between groups. And I think probably at this stage, something is better than nothing. And so I would say there are 5 key things that GP practices can do now. And these include normalising flexibility as a strength, creating a fairness-first mindset around workload, strengthening belonging through visible support mechanisms, implementing and evaluating family-friendly policies for both men and women, and then finally collecting organisational level data to really identify where those pockets of need are. Some of these actions will inevitably need to be translated into more bespoke kind of solutions for particular contexts, because every practice is different. And we've created a guide as a result of our research to help facilitate conversations around this. So I'd say that also could be a good starting place. Again, I'd argue that these 5 kind of actions wouldn't just support women GPs, but all GPs. And it would, it's about kind of redesigning workplaces for belonging, and that's belonging for all.
What do you think future studies need to look at so we get a better picture on how to better support female GPs going forwards?
I think this is a really exciting time for research in this space, because we just know so little, particularly about kind of the general practice workforce and the primary care workforce in general. We do mention some of the research gaps in the BJGP publication, but to summarise, we need a greater emphasis on intersectional research with a specific focus on how women GPs from racial and ethnic minorities experience work. Also, women GPs who are disabled or living with long-term health conditions or neurodivergence. There's also research that now needs to happen to understand the experiences of women GPs who are childless and child-free and what initiatives there are to support them. So a lot of the evidence base at the moment treats women as quite a homogenous group, and we're not. Another area is particularly around implementation and evaluation, particularly of, specific initiatives designed to support women GPs. So this is things like gender-specific conferences, training summits, professional development programs, group coaching, leadership programs, and those visual identification aids that I mentioned as well. Kind of more broadly, there's also a need now to explore in more detailed kind of general wellbeing needs of all GPs.
We've talked a lot about what you can do at a practice level, but obviously there's a national level, there's strategy, there's the overarching things we could be looking at to address all of this. And one of the things I thought was really interesting in your paper as well is that you call for a unified committee involving, the RCGP, BMA, local medical committees and the Medical Women's Federation to lobby for systemic policy changes to better support women. If you were sitting in a room with all of those groups now, what would the top 2 policy changes you think they should be fighting for so that women GPs have better support?
I mean, I really love this question. I think it's such a brilliant question, and I feel very lucky to be able to answer it, because I've just recently drafted a policy briefing. I guess I'm going to be cheeky and kind of expand it here. So there are 3 core recommendations that I would make, and this includes the need to agree a case for national action to address the structural barriers affecting women GPs. We need to invite officials to work with NHS England to develop and implement policy actions using existing contractual, regulatory and workforce levers, particularly around things like leveraging the recently renewed Women's Health Strategy. And for any action to signal intent that workforce sustainability, fairness and productivity will be addressed through system design and not individual resilience. What this looks like practically in terms of, again, leveraging and lobbying for change is things like mandating flexibility as a workforce standard, reforming workload measures, introducing fairness-first workload frameworks, investment in career development and leadership pathways, and then finally measuring and evaluating equity and wellbeing impacts. So there are my kind of key things there.
Well, thank you very much for coming on the podcast, Ruth. It's been really interesting to talk to you today. I mean, I think this is a really important subject, so I'm glad we've been able to shine a light on the research that you've done.
Oh, thank you so much.
Well, that's it for this week. Thanks again to Ruth and thank you for listening. I'll be back next week, so please do join me then. In the meantime, don't forget, you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.